Okay, Assalamu alaikum. Within the Ramadan, we are trying to read. So may Allah accept it. I will try to cover as much as possible, but actually in the during the Ramadan time, it's very difficult to take a long session. So let's see how much we can cover. So I think it is now shows. Is it visible to all of you? Dr. Julfikar, do you want to say anything? Raise your hand.
No, nothing. I said I'm present.
Okay, that's very nice. Okay, so let us start. I just want to start from the very important part. Okay. So I started from the most important part of the nephrology, that is urinary tract infection. So here you just have to be very much concentrate on the management part, because every time you get some questions with the management part, don't miss it. That is the issue with how you do the imaging. Okay, so it is one of the things, and treatment is also important. We will read a AKP case, and there is a one FOP case for the urinary tract infection. First of all, remember that when we discuss with the urinary tract infection, here some are typical and some are atypical. When it is related with like abnormal, like a child is very ill, having septicemia, there is a mass, bladder mass or abdominal mass, urinary flow low, so obstructive features, and UTI features is not responded to antibiotics, then we will think it is atypical UTI, or if it is with non-E. coli organism. So I just want to mention you that if you, it is not that they will ask you atypical UTI, no, they give us a scenario and ask the management. So you have to have an idea of atypical UTI. Otherwise, you can't answer. And also, there is a recurrent UTI, which have a specific diagnostic criteria. That means upper urinary tract infection is 2 or more, or lower urinary tract infection. Lower urinary tract infection is 3 or more. Okay. Or if there is a one upper urinary tract infection, or one lower urinary tract infection. Okay, so upper urinary tract infection or lower urinary tract infection with one. So in that cases, we can tell it that yes, it is recurrent UTI, and they have specific characteristics. How we, do the imaging. And other than if it is upper urinary, lower urinary, whatever the situation, here one of the things is what treatment you will give. Okay, so treatment of here are some questions we get from our previous recall paper, that when you are concerned with the management, then if it is like lower urinary tract infection, then only oral cephalexin. Remember, here it is written cephalexin. Okay, so oral is enough, and also it is only for 3 days. Sometimes I think 5 days, 7 days, it is written different guideline, but nice guideline is lower urinary tract infection for 3 days cephalexin. Otherwise, we will treat less than 3 months cefotaxime. Remember, 3 months or more than 3 months, you can use coamoxiclav according to the patient feature. So, is it oral or IV? It is depends on patient's presentation. But the name of the things we should know. Okay. Then I think we know that dipstick test is the primary method of diagnosis of urinary tract infection. But if you get anything like leukocyte esterase or nitrite, you have to go for urine RE, followed by you will give the culture. I mean urine RE and culture, but your primarily you will do the dipstick test. Okay, so most important things is nitrite. Okay, when nitrite become positive, then you can think that there is a high probability, but only leukocyte esterase positives, you have to search for clinical features, then you will go for the antibiotics. But here important things is how you collect the urine. It's very important, especially when you send for urine RE in that cases. Okay, so here one questions we get that less than 3 years means you can't give the midstream urine, which is the ideal method. For less than 3 years, we will give a suprapubic aspiration. Their sensitivity, specificity is very high. Okay, so you will consider these things. Now, what times I read out these things, you will forget this. This chart is very important to, I mean, practice by yourself. Okay, so don't forget this to practice. But if I say that when you do the ultrasound in less than 6 months of age, when you do the ultrasound with urinary tract infection less than 6, it means you have to do the ultrasound every time less than 6 months. But other than this, for typical urinary tract infection, it's not required. Okay, and MCUG only for less than 3 months, atypical and recurrent UTI, nothing more than this. So MCUG, previously it was different. So remember, less than 6 months, atypical recurrent UTI, you require MCUG, but less than 6 months, any kind of urinary tract infection, you require ultrasound. But it depends, immediately or you give the after 6 months. And we have to know something with the, I mean, these imaging related things, MCUG, DMS, that I will discuss later. But when you will give for atypical and recurrent UTI, just have a look. Usually they do not give very complicated things, but we have to know. So other than this, we just get from here some question that when you give prophylactic antibiotic. So the scenario was a child who having some like UTI and some features. So what you want to do just immediately after? So the DMSA was mentioned where that some problem was there. So actually, prophylactic antibiotic not for every urinary tract infection. It is depends upon the grade of reflex. If there is vesicular reflex, that means retrograde flow of urine. Urine should be flow from upper to lower to the bladder. So, but it is different in that cases. Just 1 minute. Okay. Okay, so in that cases, you have to require or patient having obstructive uropathy features, having with the obstruction, there is some surgical management is required, or there is recurrent symptomatic urinary tract infection. So it is defined more than 3 UTI per year and more than 3 months, you require prophylactic antibiotics. And from here also, I think it should be, I want to take it as a red color, that when you do the, I mean, when you do the how you manage a patients who have some scar. Okay, so with the recurrent UTI, there is a high probability of scar, and I will again discuss how you can understand the DMSA, but DMSA should be given after 6 months of urinary tract infection so that you can differentiate from recent scar or previous old permanent scar. And when there is a scar, there is high probability it can lead to some, I mean, from the scar, there is some mediators released, which ultimately give contribution to the blood pressure, high blood pressure, and there is a chance they develop to chronic kidney disease. So from here, it is taken from the guideline. So it means when there is a scar, how you follow up. So it is written here, you see that when there is there is no family history of renal problem, in that cases, unilateral parenchymal defect, in that cases, you need not to follow up. But if there is a significant scarring, then you have to give blood pressure monitoring advice in the GP center annually. Okay, annually. But if it is scarring bilateral, then you have to do the annual BP blood pressure, BP measurement, as well as urinary protein excretion with renal function every 3 to 4 years. That means you will do the serum creatinine and also the GFR measurement. So this is important area that you should know. Okay. So what I say, the reflex and other things, but they do not give any questions with how to grade the reflex. But I just want to mention you as a whole, like grade 3 reflex is indicate that it's already dilated ureter. Okay, so you know that reflex means retrograde flow, and for when the urine goes backwards. So first of all, it create no problem, but sometimes if the ureter could be dilated. Okay, so ureter could be dilated. Mm-mm. No. So ureter becomes dilated. How much it dilated? So grade 3, 4, and parenchymal defect grade 5. But I said that there is no questions like this. Theoretical questions is less. Remember, theoretical question is less in the AKP usually. I mean, most of the things understanding. So let us just see the AKP case. A 11-month-old girl admitted to the pediatric ward with 2-day history of fever and abdominal pain. Past history includes episodic temperature without identified focus, fever and abdominal pain only for 2 days. Okay. Also, it is 11 months. You have to give concentration on this. Then episodic temperature without identifying focus. Examination shows had to be withdrawn. Fractious flush. Temperature is high. Heart rate is 120 per minute high. Blood pressure 90/60. On examination, ear, throat, chest, no abnormalities. Examination abdomen shows to be soft without curdling, but some tenderness in the suprapubic area and tenderness in the loin area. So only 11 months child is looks like having high grade fever, some urinary complaint, although there is no urinary complaints directly, but there is tenderness on the loin and abdomen soft. Yeah. So suprapubic area tenderness and loin area tenderness. So looks like it could be acute pyelonephritis because high grade temperature vitals become unstable. But there is a episodic temperature. You have to remember this point, episodic temperature. Okay, comes to the next point. A bag urine is obtained, urine dipstick positive for nitrate leukocytes. The sample test sent for culture sensitivities. What would be next most appropriate step in the management of this child? Here, question is that what next management step? Obtain a clean catch urine, then start IV antibiotic, obtain a clean catch urine, then start oral antibiotic, obtain a clean catch urine, but await culture result before starting antibiotics, obtain a second urine sample of suprapubic aspiration, which after which start IV antibiotic or oral antibiotics. So the points which is required, I just discussed. So what do you think? What do you think? Please write in your chat box what could be from our discussion. I mentioned that at some age we cannot take clean catch midstream urine. That you have to remember. Okay. Okay, Dr. Rejwan, I get it. Thank you. And you're saying that it is D. Let us see again what is the D. So suprapubic aspiration, second urine sample by spraying, after which start IV antibiotics. So IV antibiotic, why? Having renal angle tenderness. Just it is right that tenderness in the loin area. And suprapubic area, 90-60 blood pressure, and temperature 38.5. So you have to here think over the less than 3 months. There is a fever criteria now. So less than 3 months, and from 3 months to 5 years. Some are red flag signs, some are, from where you have to justify it. I think 11 months old girl, heart rate 120 is not abnormal from this area. So you have to go through the, fever criteria, and then you will, always when you get fever and any fever things, then you have to go through the fever criteria, and you will. Someone here joined, which is name. I don't get it. Oh, just leave. So let us explore these things. Eve Angel. Who is Eve Angel? Just 1 minute. Okay, so who is here? Eve Angel. Can you please tell me your, the name which is known to me? Okay, so if you just see the fever guideline, and here less than 1 year heart rate, when more than 160, then it is tachycardia. Other than if you see that for this child, any high risk, may pale, mottled, ashen, social cue, looks ill, nothing is related with this. Even heart rate is not even the intermediate criteria. So you see, intermediate risk, it is not there. And temperature is 3 to 6 months, 39, more than 39 degrees Celsius. Its child is 11 months. So temperature 38 degrees and more than 38 degrees Celsius. For this child, temperature was 38.5 degrees Celsius, but it is for the less than 3 months, not 11 months. Okay. And if you go through the traffic light system, then you will have to give antibiotics or not. You don't have to give antibiotics actually. Okay. You have to immediate treatment. Here it is written. If no diagnosis is managed child at home with appropriate care advice. So for the lower urinary tract infection, you have to give the oral antibiotics, not IV antibiotics, because child is not fulfill the criteria of intermediate, or it is the less than 3 months, but 3 to 11 months. So if you just go through this the guideline properly, then you will get the child having no features of intermediate risk or lower risk, higher risk. So child is in low risk. In that cases, you can give the child oral antibiotics or not, but it's not must to be admit. Okay. For that reason, we don't want to go for IV antibiotics. But for sure, for the scenario, every time I just want to go for the IV antibiotics. Although I know that I have, I mean, this result in the AKP case could given differently. Okay, so it is actually, if you just go through the criteria, then you have to go for oral antibiotics. Otherwise, you will go for IV antibiotics, especially 120 heart rate. I was thinking even that it is high, but when we see the criteria, then less than 1 year heart rate is not 120 is a tachycardia. Here they define it as a normal. Okay. um but yes, the child having tenderness in the loin means it is, I mean, upper urinary tract infection. Still, if you just follow the fever criteria, fever guideline, traffic light system, you can't give IV antibiotics. You have to give here oral antibiotics. Supra pubic area, there is a tenderness, lower urinary tract infection here could be. So we have to give the appropriate investigations. Then if it is proof that IV antibiotics required, then we will go. So I think you understand these things, but still it seems to be it should be, mm, okay. Let me check. So who is here? Evangel, can I know?
I'm Elisha, ma'am.
Oh, thank you. Nice to meet you.
Nice to meet you.
Okay. Um, so you see that how the AKP case is here confusing. Okay, so whatever it is related with the infection chapter, infection chapters, pediatric guideline, which is you get in your infection class also. If you can, some of you already did this class and you can remember, and also if you go through the guideline, you can understand that it's very important things to I mean, remember all the points, the chart, which is very, very important. Okay, so we will go through these things and we'll take this information from there. Here, appropriate, we will take second urinary sample by suprapubic aspiration, after which start oral antibiotics. Because if we take this and immediately we can understand from dipstick test, which is the, I mean, UTI is there or not. But all the things are in favor of our UTI, nitrite, leukocytes already post tips. But 11 months, so midstream urine is sensitivity specificity is not appropriate. It's low. So we cannot rely on leukocytes and nitrite dipstick test only. We have to go through a urine sample as well, and then we'll start. So two things here: how we will take the urine, and then what antibiotics will give, oral or IV. These two things here we discuss, and you have to go through the, I mean, case book if you can go through, but they are just as a whole discussed with the UTI. Okay. Then which of the following imaging schedule is appropriate? Select one answer only. So now imaging schedule, you understand how it is, what importance it has. So no imaging in the acute period, but renal tract ultrasound only within 6 weeks. Okay, Dr. Fahmina is very appropriate. I mean, very rapidly give the answer. Okay, that's very good. No imaging, no imaging is necessary. 11 months. Okay. Renal tract ultrasound and MCU within 6 weeks. Ultrasound during the acute phase. Infection if normal, no further investigation. Not a scan during the acute infection with DMS scan 6 months post-acute infection. Okay, so why you are thinking E? It is one of the answer, one of the things, or other than E, what could be? If you think then no, E is not the right answer. So anyone having anything different thinking? Okay, so Here, child having anything atypical UTI features? Do we get any atypical urinary tract, atypical UTI features? Renal angle tenderness is not mentioned, okay, as a, I mean, atypical uterine features. So only atypical and recurrent UTI require DMS scan. Okay. So if you see that I do not get anything atypical UTI features. Oh, just I want to see that any atypical UTI features is there or not. So it's not seriously ill. It's not any poor urinary flow, mass, septic features, raised creatinine, or non-E. coli within 48 hours responding. So it is actually, they are thinking here, we are thinking here, we should thinking like this way, that it is a recurrent UTI because past history include episodic temperature without any identified focus. Okay. For recurrent UTI, we have to take the renal ultrasound scan with DMS scan. Okay. Child is less than 11 months, so more than 6 months, and ultrasound scan during the acute infection and DMS scan 6 months. It seems it is the right answer because if renal ultrasound during acute infection normal, no further investigations, no favor of other things. So it is actually due to recurrent UTI. And here our plan of management is go for ultrasound during acute and DMSA 6 months post acute infection. But actually, recurrent UTI is not proved. Okay, so recurrent UTI is not proved, but how can we say that it is atypical UTI? If we take the seriously ill, but child is not seriously ill, and there is tenderness is there only, septic features is also not there, blood pressure is normal. So in that cases, we have to take the E. But remember, during the acute infection, if you just think that in the acute infection, I will go for ultrasound, it is only for the atypical UTI, but not for the recurrent UTI. But you can go for D, or you don't go for the C, MCUG is only for the less than 6 months. AB is totally incorrect statement. So you have to go for E. E is the right answer, but just remember that atypical UTI require immediate ultrasound, but recurrent UTI not require immediate ultrasound. They can do the ultrasound for after 6 weeks or within 6 weeks. Okay. But here, atypical UTI, any features, I do not get any atypical features. If it is atypical UTI, that means you have to give the IV antibiotics, actually. So some disparity here. Okay. So is it clear, or having some issues? Non-E. coli, Dr. Shatabdi said non-E. coli organism, but here they do not mention you non-E. coli or mention you. Am I missed it? I don't think. Oh, you are very right. Thank you. Isolated, I do not read it. The culture result from second urine sample shows an isolated growth of Klebsiella. Yeah, this is the things. It is atypical UTI as Klebsiella is identified. Very, very, very right. Thank you. I become very much astonished why they give, I didn't read this, okay? So why they thinking it is atypical UTI? Because remember, atypical UTI not atypical UTI only requires immediate ultrasound after 6 months of age. So this is the cause. I do not read these things, your comments. So very right. You are very right. Okay. So you see that these things are very, very important. The whole that I just covered. Okay. This whole things is very, very important. Now, this is a scenario which is 7 years old boy, high fever, vomiting, dysuria, enuresis since the age of 5 years. So it is known to you. 7 years child having 24 hours fever, dysuria, enuresis. She having high fever, unexplained, managed at home. Then past history of urinary tract infection 6 months ago that was managed with primary care. It was a UTI. So 6 months ago there was a lower urinary infection because it is managed within the primary care. Developmentally appropriate, no problem. Daytime toilet train, nighttime passing large volume urine, that does not wake him up. Okay. Then on examination, weight is 0.4 centile, 0.4 centile, pale and febrile, temperature 39, very high grade temperature, and blood pressure normal, everything is normal, leukocyte, okay. So which of the following important next step, next test? So please comment. Here you are getting a child who having urinary tract infection, all the things you get, how they are presenting. So now you will tell. Okay, so urine microscopy and culture is the most important next step. You will take blood culture only if you are think it is septicemic. Otherwise, blood culture for UTI not always give you some organism. Okay, so child having high temperature, but at this age, this temperature is not any features of septicemia or something. Okay. Following initiation of treatment, which is the next investigation to be requested. So you get that this child having nitrites, leukocytes, and positives, having flank tenderness, blood pressure. But only problem is you see here height, weight is compromised when child is pale. Okay, you are getting these things. This is the red flag. Just remember, this is the red flag. So child having failure to thrive, child is pale, and previous 1 episodes of UTI. Previous 1 episodes of UTI. 1 episodes of UTI of lower urinary tract, and now the temperature and everything shows that it is upper urinary tract infection. So what investigation you want to be suggest? Anything we having here? So 7 years and other features. So it is not mentioned that after 6 months what you are want to suggest. Okay. So here everyone telling B or D or something. Okay. So just so they want to say what is the next investigation to be requested, and so in that cases it is not the, I mean, immediate, first what you will take, you have to mention these things. Okay. So for recurrent UTI, you have to you have to request DMSA, but first you will ask for renal ultrasound scan, because you have to prescribe within 6 weeks. Okay, and for the recurrent UTI, but DMSA scan would be after 4 to 6 months. Okay, but yes, when there is recurrent UTI, then we'll prescribe DMSA scan. Okay, so I think UTI is over. So you understand from where you have to read, I mean, which area you will suggest. Um, just 1 minute. My child. No. Okay, then we will read calculi. Actually, from renal calculi, remember that they just here here we just get something like idiopathic hypercalciuria related questions, mainly when they are having a stone. It could be asymptomatic, there could be typical pain and urinary tract infection features. So one of the most important cause is idiopathic calciuria. Okay, idiopathic hypercalciuria. So how can you diagnose? Some questions you will get. Many times they give you. You have to diagnose it. I mean, first you will confirm your diagnosis by the X-ray or ultrasound, but cause you have to go for urinary calcium creatinine ratio. So just these questions came several times. Calcium creatinine ratio would be high. And there could be some family history, and other than there is no cause why there is calcium creatinine ratio high. Okay. So it is called idiopathic hypercalciuria. But we know that sometimes it is related with I mean related with sickle cell anemia. Okay, in that cases there is more cellular breakdown, and other disease could be associated. And when it is UTI, then Proteus is the causative organism. Salmonella could be with when hemolytic disease. But familial juvenile hypercalcemia, familial idiopathic hypercalciuria is important cause that we can discuss, we can diagnose by such method. And what are the other disease? You can remember distal renal tubular acidosis. Not forget, it's not the proximal renal tubular acidosis. Okay. So distal renal tubular acidosis or type 2 renal tubular acidosis could be a secondary cause. And here just I want to mention you that sometimes they give a stone and just give the urinary pH to diagnose this case. So you can understand. So if it is, you get that pH is high, more than 5.5, then it is distal renal tubular acidosis. Okay. But if it is low, then it excludes distal renal tubular acidosis. Here we discuss, okay, and it is very important. Several times these questions came in the exam. Treatment related question is very less. Just you took this X-ray where you get this stone, okay, bilateral nephrocalcinosis from X-ray. How you get? I mean, X-ray related and imaging related many questions you have to face. So you see these things and go for the Google and see that how it looks like from the X-ray nephrocalcinosis. Okay. There is diabetes insipidus. So again, diabetes insipidus having polyuria and polydipsia. So if you get these things, I mean, you get child having polyuria, polydipsia. In that cases, you have some differentials. Remember always, because they will give you some, some data. Okay. So one of the things is DI, polyuria, polydipsia. One of the things is renal tubular acidosis. It could be Bartter. It could be psychogenic polydipsia. Okay. So DI, they have polyuria, polydipsia, but there is no respiratory distress or metabolic acidosis, but they have failure to thrive because of DI, polyuria when there could be dehydration. And they have electrolytes is hypernatremia. Okay. When we go for renal tubular acidosis, they have polyuria, polydipsia with metabolic acidosis features with failure to thrive, along with what we get. We can get hypokalemic, hyperchloremic metabolic acidosis. Okay. But there is, when there is a hypernatremia, so remember, there would be serum osmolality high and urinary osmolality is low. So urine is dilute. Okay. So the pathogenesis, that ADH is not working here. So problem with ADH synthesis or work on. And if we go for Bartter syndrome, here we get hypokalemia along with metabolic alkalosis. Just 1 minute. So metabolic alkalosis. Okay, metabolic alkalosis is Bartter, but still they have polyuria, polydipsia, dehydration, the age is low. Okay, and psychogenic polydipsia never have psychogenic polydipsia. If they are, then it becomes confused with the DI. But remember, psychogenic polydipsia could have very dilute urine. Psychogenic having dilute urine, but never ever you get hypernatremia. They could be normal sodium. So it is as a whole a diagnostic way, remember. There is something more that is not related with polydipsia, polyuria, but there is some question like SIAD. So if they give you SIAD, remember they will give hyponatremia. Hyponatremia along with some abnormality, like the child is on pneumonia features or meningitis features. Okay. Why it is not working sometimes? So pneumonia or meningitis feature is SIAD. There is another thing, cerebral salt wasting. So cerebral salt wasting having some problem with cerebral salt wasting having some, so brain surgery. Okay, cerebral salt wasting. They could have oliguria, they could have like normal sodium, but they have also diluted. So this is the fallacy that sometimes we become confused. So let us discuss these things. And diabetes insipidus is very clear cut. If you see, then investigation is water deprivation test, but it is nowadays not. Discussed water deprivation test because of chance of it is only have to done in the hospital, risky. Other than urinary osmolality is a diagnostic. So urinary osmolality usually less than 300 milliosmol per kg for the nephrogenic DI. So until otherwise proved. So problem is here, serum osmolality is very high, but urinary osmolality is inappropriately low. And when you get, then you have to give DDAVP and you will see that how they respond. If DDAVP you give, that means vasopressin or it is the ADH, synthetic ADH, they will, what they will do? They will increase the osmolality. Okay. So how it, what will happen? When central DI, then the osmolality will be raised because here central DI having problem in the pituitary gland, they cannot synthesis. So if you give, then the osmolality increase. But in the renal cause, diabetes insipidus, due to obstructive uropathy, lithium toxicity, or diabetes insipidus due to nephrogenic cause, that is X-linked dominant, then you will not get any response with the DDAVP. That means it is nephrogenic DI. Okay. So sometimes they will give you, like you have to choose in between the CDI and NDI without any interpretation. So if you see that the patient condition is very poor and urinary osmolality is very low, then you can just go for nephrogenic DI. So let us discuss a case. 3-year-old boy is admitted to the hospital with a week-long history of progressive lethargy and sleepiness. He is drinking slightly more than the usual, but his appetite is reduced over this time. There are no other specific symptoms, and in particular, no indication of the headaches or visual disturbance. His parents and one siblings are well. There is no known illness in the family. Not taking any regular medication apart from the occasional paracetamol. On examination, drowsy, aroused but arousable. Glasgow Coma score is recorded as 10. His eyes are slightly sunken. His heart rate is 150, blood pressure 70/40. Heart some normal, respiratory 30/40. There is no recession, breath some normal. No abnormalities are found on examination of the abdomen. Neurologic system funda is normal. Investigation, blood, urine, sodium, potassium, bicarbonate. Sodium is very high, you see. Potassium is it is sodium, potassium 5.3. So 5.5 up to 5.5 normal, so it is normal. There is 28 bicarbonate, 20 up to 26 normal, so slightly high. Glucose, creatinine should be right side by side, otherwise difficult to understand. Okay. So glucose normal, creatinine 144, I think normal. Yes. Bicarbonate. Okay. So osmolality, urinary osmolality is low, very low. Okay. So what is the most likely cause of his electrolyte abnormalities? So it is a very easy question, no? 3-year-old boy, how having lethargy, sleepiness. There is nothing complain with the visual problem. There is dehydration. Okay, dehydration features is there, tachycardia, and you get hypernatremia. So I think it's not very difficult, but didn't give anything like polyuria, polydipsia. So we are very much used with these things. Up to 28 normal, I think. So it is also normal. Okay, so it is nephrogenic DI. It's not primary helper. So you see that if you do not remember exactly the potassium level, bicarbonate level, then it is difficult to you. Salt poisoning, remember, salt poisoning having severe hypernatremia, more than 180. And there will be some precipitating cause. Okay. So you are giving excessive amount of salt in the feed, like child is sippy and NG tube feeding is going on, and this child develop convulsion, you get very sodium, high sodium. Okay, so in that cases you can think of Sia always having hyponatremia. So by this way, we can just remove these things. And rotavirus diarrhea is not like this. Most appropriate fluid regimen to provide at this time. So here, remember, when oral fluid is there, I mean, hypernatremia management, it is now hypernatremia management. So hypernatremia, just you write it what you are thinking. Write it what you are thinking, like IV fluid or oral fluid. Just think IV fluid or oral fluid first by this way. Okay, so it is DI management, but when there is, you get that this child having sodium, high sodium, you have to give the management of hypernatremia. And hypernatremia, your first task is always to go for vitals. You check the vitals. If shock feature, you will give the shock management. And the child is not in shock, and when the child is capable to take fluid orally, you will give fluid oral ORS, and you are giving here ORS. You see, you are here, use the right answer. You have to give the oral fluid, but child is not capable of fluid taking oral fluid, then you have to go for IV, because oral fluid, when renal function is appropriate, they can excrete appropriately. Main problem is hypernatremia, means if you are rapidly correct, then there is a chance of cerebropontoral hemolysis. Cerebral hemolysis could be, okay, cellular breakdown could be, so you don't want it. You have to give the management, within 48 hours or 72 hours, when child sodium level is more than 170, 70 or more than 170, 170. Okay, so in that case 72 hours, otherwise 48 hours. You can't give more than 10 millimole per day, correction. More than 10 millimole correction you can't give. You have to give the correction within 10. Okay, so 24 hours, only 10 change you can go. So this is very risky when you give IV. That means oral fluid is appropriate. Okay, oral fluid at maintenance rate when child having vital stable and other things stable. But if it is 170 or more than 170, you have to go for hemodialysis. 170 or more than 170. Okay, so it is the actually one, um, uh, there is something like hypernatremia management issue. Okay. So autosomal recessive polycystic autosomal dominant kidney disease, there is one ultrasonogram related things, like ultrasound having some cyst, and they ask you what is the things. If it is complicated, then they will give you some scenario. Ultrasound is not very common for, so if you see that this is the autosomal recessive polycystic kidney disease, multiple cysts is there. So if they give you ultrasound, then I hope and I believe that they will give you some scenario like there is some, there is a one big cyst and family history of other cyst like cerebral aneurysm, pancreatic cyst, other kind of cyst or aneurysm related things is there, then you will think of autosomal dominant polycystic kidney disease. Diagnosis is genetic analysis other than ultrasound. Okay, so primarily you do the ultrasound, then genetic analysis to see that autosomal dominant or recessive. Recessive kidney disease is something like after birth you will get recessive kidney disease. Okay, and they have huge kidney, very enlarged abdomen, and there would be some other things like esophageal varices, hypersplenism, congenital hepatic fibrosis, then you think it is autosomal recessive kidney disease. Tubular disorder is very, rickets is very important. So you have to very cautious with these features. Okay. I think it is we discuss more with the nutrition chapters. Yes, rickets related things. So just remember this difference, and only PTH is normal or low in case of X-linked familial hypophosphatemic rickets. There is a task case. It was in the in a part one. There is a task case which is having some abnormality. Okay, interpretation, which was wrong. Okay, so it is X-linked hypophosphatemic rickets normal or low PTH. Other than everyone having high PTH, renal disease having high phosphate, it is just the exception. Okay. And vitamin D dependent rickets, how can you understand? When you give the rickets management like vitamin D, it's not responding, then you think it is some problem in like vitamin D dependent rickets type 1 2 or 2. So one is genetic analysis, like 1 alpha hydroxylase mutation, and here also the same features: phosphate low, calcium low, high alkaline phosphatase, high PTH, and also vitamin D is low. But just exception type 2 having high active vitamin D. Okay. And these things like vitamin D dependent rickets type 2 having some alopecia, dental problem, you can see these things, and severe rickets. Okay. And vitamin D deficient rickets having specific features that could be discussed in the nutrition chapters. But this chart is very important, you have to remember. Bartter-Gitelman syndrome, that we discussed the same things. So just you have to remember this hypokalemic, hypochloremic metabolic alkalosis, and you will get high urinary renin and aldosterone. Just Bartter and Gitelman difference is Gitelman is more, I mean, not very much early age. Gitelman is late childhood. You will get less severe features, and you will get that hypomagnesemia always. Butters having some percentage could have hypomagnesemia. Otherwise, the main things you will remember that hypokalemic, hypochloremic metabolic alkalosis. Then it would be enough. And again, renal tubular acidosis, how we can reach these things: hypokalemic, hyperchloremic metabolic acidosis. Okay, so here we have to just remember the urinary pH. Okay. Distal RTA, that is type 1 RTA. Maybe I one time said type 2. No, it's type 1 RTA. Urinary pH never below 5.5. That means pH is high, more than 5.5. Okay. So, but type 2, that's proximal RTA low. So here one important things comes several times. We just see these things, that is the cystinosis. So cystinosis features, I mean RTA features, and cystinosis become diagnosis. How can? So one of the important things is proximal RTA. When we discuss about the proximal RTA, so maybe cystinosis written other pages. Just remember, when we discuss about the proximal RTA, how they are. So same metabolic acidosis, hypokalemic, hyperchloremic, but they have amino aciduria, glycosuria, phosphaturia sometimes. So amino aciduria, phosphaturia, glycosuria, they are. And one of the causes of proximal RTA is cystinosis. Okay. So by this way, several questions came. Okay. So we do not get much questions with the AKI. AKI, just remember here, there is some difference in between the pre-renal, post-renal by the urinary sodium. In pre-renal, urinary sodium less than 20. Otherwise, everything is high. Okay, by this way, we have to differentiate, and treatment is appropriate fluid and furosemide, then dialysis. So dialysis only done by the pediatric nephrologist. You have to send them pediatric renal center. So So just read out these things one time when you have to refer. So, when dialysis requirement is there, okay, other than this child having HUS, then immediate renal unit referral is required. Discussion with the typical HUS, but for atypical HUS, early referral. Other anuric patient require dialysis or fluid overload, require diuretics, but diuretics not act on. Severe hyperkalemia, not responding to other measures. Severe hypertension. So when require, dialysis, then renal unit. Or your things to be CKD, then also you have to refer. So CKD related some questions in the AKP. You do not get any questions, in the part 1 exam. So here you can get it. And this is very typical. CKD related, these questions is very typical. You see 7 years new format case. 7-year-old boy presented with 18 months history of poor growth and failure to gain weight. His appetite was poor and he was lethargic, such that he had to be carried home from school. There was no significant past medical history on examination. He was pale and his weight height were 0.4 percentile. He had a heart rate of 104, blood pressure 120/65. So what you get here? So failure to thrive, one is failure to thrive. And pale. Blood pressure for 7-year 128/65. 128, maybe it's high range. Systolic murmur. So it could be due to anemia. Hemoglobin 4.5. So there must be some murmur could be for that reason. Okay, so sodium, potassium, okay, but creatinine 907 is very high. And you see sodium is very low, phosphate is high, bicarbonate is low, so metabolic acidosis, PTH is high, urine having hematuria, proteinuria, so end-stage renal failure was made. So what do you think? When you get any patients having failure to thrive, hypertension, anemia, bony changes, undoubtedly it is CKD. Failure to thrive, hypertension, anemia, bony changes, or you can think failure to thrive with bony changes. So bony changes means rickety change, sometimes obvious, sometimes hypocalcemia, hyperphosphatemia, and high PTH. Okay, so it is CKD. Okay, and how can we say end stage? Because you see creatinine is very, very high. Okay. So for this is very typical questions. Try to remember this question. New format made very good way, and you can get some sample paper CKD related questions, and also the it is written. There is one recall question. It's SLE and having impaired renal function and other features. So SLE is there and impaired renal function. Remember, it is actually not always CKD. So it could be AKI also. The question is not directly related with CKD. So SLE could have AKI if it is persist more than 3 months, some renal abnormalities, and it's CKD. And SLE, if they have high chance to develop renal involvement. So our CKD having some specific problem that we have to address, very important. So you have to here three things you have to choose: echo, wrist X-ray, chest X-ray, bone marrow spirit, renal ultrasound, 24 hours urinary protein collection, parathyroid isotope scan. So take 3 answers. So you know that they can give you 3 questions. 3 answer even they can ask. So what do you want to choose here? If you first I have to check that anything so 1 to 5 Dr. Fahmina said 1 to 5. Okay. So echocardiography, why we have to give? Because we want to start uh, hemodialysis in case of usually when there is this massive high creatinine, ESRD, then echocardiography before starting of hemodialysis must. Okay, because there could be some structural change, some murmur is there. So if there is slow murmur for anemia, not always require, echo. So it is the reason of starting dialysis. Okay. And there is wrist x-ray. Wrist x-ray also. Okay. So here we have to do the wrist x-ray. Wrist x-ray, why? Because we do not have to know why, bone age, because we know that this is CKD. So here important things is some rickety changes could be there because of hypocalcemia, and which could be helpful for us for further management. Okay. And renal ultrasound scan we have to do to know the cause. Sometimes abnormal kidney could be the one kidney having multicystic dysplastic kidney or other, although 7 years old boy, in that case multicystic dysplastic kidney could be changed at that time, and there could be hypoplastic kidney. So you have to do the renal ultrasound to ascertain the cause. No role of urinary protein collection or parathyroid isotope scan if we think that there is some abnormality for parathyroid gland itself. Okay, so it is not primary hyperparathyroidism. Okay, now long-term management, what things we will go for? We have to think of, they are always, it is like long-term management, like we have to go for nutrition and growth, and we have to see the metabolic bone disease. So how we can give calcium, then active vitamin D3, alpha calcidiol. Okay. Also you have to go for blood pressure management, very important. These things, here they just don't mention about directly anemia, but nutrition and growth is on the under this heading. So the diagnostic criteria was failure to thrive, you will address this. Hypertension, you will address this. Metabolic bone disease, bony changes, you will address this. Okay. So anemia also there. By this way you will manage. It's very important. There, yes, new format. Renal vein thrombosis related, some questions are there. Just remember, hypertension, recent onset hypertension, or there is hypertension with hematuria with mass in the kidney region. Okay, so mass, then hypertension, and then hematuria. This is renal vein thrombosis. Renal enlargement, flank pain, irritability in baby, hematuria, macroscopic, microscopy, declining renal function. These are the classical example. That I said, but remember what I said. Then you can make your diagnosis very rapidly. And ultrasound of the abdomen with Doppler study you will give. Okay, Doppler study with the ultrasound by Doppler method. Okay. Then I think management issue now not important. hypercoagulable state, there is a history of umbilical catheterization could be there. Now I just want to say renal hypertension. I mean, sometimes there is with the hypertension, so cardiac cause could be, endocrine cause could be, some are kidney cause. Okay, so when you get that these types of features like hypokalemia and metabolic alkalosis, creatinine is normal, and hypokalemia and there is hypokalemia and hyper metabolic alkalosis, then you will think of two things. I mean, your differentials is renal artery stenosis, and we know hypokalemic metabolic alkalosis also with the Bartter syndrome. Okay, but you will not think that hypertension would be there. With hypertension, if it is there, then renal artery stenosis and primary hyperaldosteronism is could be a cause. Okay, just remember these two differentials. Renal artery stenosis would be renin high. Renal artery stenosis would be renin high and aldosterone high. But primary hyperaldosteronism, if you think, then their renin will be low. Just these things. Okay. There is skin rash. So just I'm discussing with some like scenario how it could be. So skin rash, if they are, then what could be? I mean, hypertension with the skin rash. So skin rash with some renal association and skin with hypertension with some renal. So, you know, the HSP having a specific skin rash. Okay. But yes, it would not be very long time, but there could be some skin rash. And they impair renal function. You know that HSP having specific rash would be there. That is predominantly lower limb, and there be extension surface involvement and it is not blanchable rash, and this along with there could be some abdominal pain and some renal hematuria, proteinuria, impaired renal function. It could be SLE. Okay, it could be SLE. So SLE having other body organ involvement as well. And what other things? It could be acute post-streptococcal glomerulonephritis. Also, there could be some rash. Okay, and renal involvement, hypertension. So sometimes they give this scenario. We will discuss with the PSGN in details. I mean, not that much detail, that's required. There is many questions with the hypochloremic, hypokalemic metabolic alkalosis. Okay, just these things, hypochloremic, hypokalemic. So always we think this is Bartter, but there is something like, you know, cystic fibrosis related these features due to repeated vomiting. It could be happen, and then it is called pseudo Bartter, hypochloremic, hypokalemic. Due to repeated vomiting, it happens. Child is known as cystic fibrosis. Then you call it pseudo Bartter. And if it is pyloric stenosis, then yes, pyloric stenosis having this these features, okay, electrolyte features. But we know pyloric stenosis having vomiting, failure to thrive, constipation also would be there. Okay, vomiting goes distant side. Use of diuretics also can lead to these features. Okay, and if child is treated with cyclosporin, because there are some renal cases who are getting cyclosporin, and scenario would be like renal transplant, cyclosporin, something like they could have hypertension, they could have gingival hypertrophy, they could have hypertrichosis, liver enzyme problem. Okay, so this is the things. So some, I will now discuss some imaging related things. You know already, protein creatinine ratio we have to do sometimes, and here something we discussed. Just DMSS scan. So DMSS scan is gamma camera X-ray that shows that how it is looks like, and if there is any gross anatomical abnormality, you can get the kidney DMSS scan. Okay, so abnormally placed, or you can get pelvic kidney, or you can get small kidney, okay, and a scar as well. So there is some questions related to this, and they will give you some like DMSS scan features, and you have to identify. If you just see the more pictures are with the radiology classes, we will discuss more, some pictures, and you can see some DMSS scan features in the Google. Okay. Then MAC3 related DTPA or MAC3. Nowadays, MAC3 is more popular, so MAC3 can done repeatedly as a follow-up. So why it is done? To see that where is the obstruction, or the obstruction is, you can suspect that this obstruction is there, so it can differentiate true and pseudo obstruction. And sometimes after operation you can need it, so mainly obstruction related. Okay, so after you give the dye, IV route, the child kidney taking the dye, okay, and the graft goes up, and then it excreted. Okay, so the grafts goes down. So when it is not goes down, so this graft, after giving furosemide, it goes down. That means it is not true obstruction. And here another graph shows it goes upward even after give furosemide. So what happened here? Goes upward. That means true obstruction. And most common is pelvic junction obstruction. Okay, so DTPA can or MAC3 can identify this obstruction. So just again, the radiology chapters, we can see some more these types of pictures. Okay, another thing is MCUG, where we just discuss about, that is a X-ray, where you will catheterize the patient, then give the ray, and then you will see how the bladder outline. Okay, and any post-urethral valve is there. Very important to know the post-urethral valve. Okay, that is the MCUG, and before the operation you have to give antibiotics. So it's not the prophylactic dose, it's the treatment dose. Okay, double the dose on the day before, day of the test, and day after. Hypertension related some question we get. So just to discuss these things. A 14-year-old boy arrived in the hospital with status epilepticus. He has surgical repair of lumbosacral myelomeningocele in infancy, had a decompression of the foramen magnum for artery malformation 2 months before this admission. One thing I want to say, just those who are giving exam, don't go for much in the new format case now. Even that I discuss here, it's enough. Okay, so don't go for repeated reading, rather go for repeated reading of the topics, recall topics. Okay, so new format having some idea of new things. So some persons can tell you that there are many books, like when I read these things, I read some unnecessary books that is not needed. So new system is not support this. There is so the old person who are not attached with the system and who are not follow up the exam scenario, they can still just very loyally they can say their experience. Okay, so like survival good is a one kind of books which is good, okay, but it's not the new system. Even if when you read the survival kit book, you get there's some task things they are discussing, clinical examination they discuss. So how it could be a, I mean, very correlatable with the new this system. So the new form, I mean, survival guide is a books of whole MRCPCH. It's not required, truly. But okay, if you love to read, okay, so you can read every book, everything you can read. No one can harm. I mean, reading is not bad. So it's your wish, but which is important that I'm just telling these things, okay? Even new format having some case and something written very unnecessarily, okay, it's not goes in favor of exam way. It is the notebook type. If I write some books and it is published in the Amazon, then it becomes the book of MRCPCH. Yes, I have now that capacity, but if it is I'm writing these books and after 10 years if I not update this, so is it I mean, is it okay? No. And RCPCH having new books, you know, the AKP books, RCPCH. So this is the standard book now. If when RCPCH published this book very recently, so it is overweigh all the others book. So if you want to read, then read the RCPCH AKP master course book. A very nice book. Even it is better than the soft book. Soft book is many things is right in bogus way, but their scenario is very nice. They are, I mean, scenario plus very many chart and something. It's very nice. Okay. So new format, all the things are not very important. It is not the RCPCH books. But yes, when RCPCH, there is no book from the RCPCH. When I gave the exam, there was no book in the RCPCH for the AKP, other than AKP guest book. So that times we just follow the new format. New format was most important that times. But now take the like position of the master course book. Okay, then new format book. But some things, some unnecessary things in the new format. Okay, so I don't put it. And when I revise something, I will remove even. Okay, so remember these things. So this case is when we discuss the scenario based. So our MRCPC is scenario based. Okay, many things, even clinical scenario based, very important to understand. So this is the things which will clear your idea and which helps you to remember. Just you are reading a theory, you can't remember these things. It is not applicable for all, but majority of the average, those who are not very much extraordinarily, I mean, to memorize, they can memorize more with the scenario. So we are just reading the scenario and try to remember, okay? 14 years old boy arrived in the hospital with the status epilepticus. He had surgical repair rhombosucral and then unnatural malformation, and the child was having some seizures. Child Glasgow score low, pulse 70, bradycardia for 14 years, blood pressure was high. So you see, it is a Cushing effect. His electrolyte shows sodium, okay, potassium, urea, creatinine is very high, bicarbonate acidosis is there. So what is the cause of his raised blood pressure? It's very easy, na? Very easy. But you see, hypertensive encephalopathy secondary to chronic renal failure or obstructive hydrocephalus, phenytoin ingestion, acute tubular necrosis secondary to poor renal function, in a status epilepticus. So actually, this child having status epilepticus means when there is high creatinine, then it can lead to convulsion. When there is blood pressure high, it can lead to convulsion. Okay, so it is hypertensive encephalopathy secondary to chronic renal failure. One questions may be very old recall we get with the Little syndrome or Gordon syndrome. So Little syndrome, just remember they have hypertension and with hypokalemic metabolic alkalosis having hypertension. Okay, but Gordon having metabolic acidosis, hypertension, metabolic acidosis with hyperkalemia. Okay, but their renal function is normal. So if it is possible, then remember the Gordon and Little syndrome. For the enuresis, not very much questions. Just remember, enuresis could be sometimes require management less than 7 years if child is compromised, okay, for this enuresis. And emotionally, if they have problem, then we'll go for intervention with the medicines. Otherwise, first, before 7 years, we give the reward system, we keep the lifestyle changes, habit, so less fluid after evening, and they will follow the chart. And that means if they having constipation, then you have to give the constipation management. They don't take any coffee, much juice. So these are the initial management. But it is mentioned in one recall that you have an enuresis child and having constipation. So what you will do? You do not go for any drug type management or something. You have to constipation management, that is macrobol. Okay, so it is your initial treatment, because and the scenario was primary enuresis, means there is nothing, child with never continent. Okay, so it is primary enuresis. But secondary enuresis means child was continent then lost. Okay, so this lost, why? That was due to constipation or other effects. So enuresis sometimes can come with sexual harassment as well. So the child was living with a step father and many other their step brother, and child is very shaky, having recent onset enuresis. Child was very gloomy, always remain in the home. You have to suspect in that secondary enuresis due to sexually harassment. Okay, so it can comes this way as well. But after then, more than 7 years, you can go for desmopressin, but your first treatment is alarm. Okay, after then you can go for a desmopressin and follow up. And if it is not improved, secondary enuresis, daytime incontinence, if they are, then refer. Okay, so I think not required many things here. So some hyperkalemia related question is there. So remember, ECG change means you will give IV calcium gluconate. Why? Because IV calcium gluconate can stabilize the cardiac muscles. So you are just protect the child from arrhythmia. Other than this, when more than 7, you will give the specific management, that is salbutamol with glucose infusion and furosemide, glucose and insulin. Okay, salbutamol nebulization. So these are the management you can give. Soribicarb if acidosis. If not improved, then dialysis. But more than 6, what you will give? More than 6, you will just give stop the potassium containing drug, and also you will remove any nephrotoxic drug. So supportive measurement, then it will be okay. Hypernatremia related we discussed, but it is mainly neonatal. Okay, so we will discuss it at neonat. Metabolic acidosis alkalosis diagnosis, is it what kind of acidosis alkalosis? It is less asked here. Okay, so if you have not that much idea, just go through this. Okay, or you can ask me if you have any issues here, so I can share with my part one lectures. Okay, but less questions, no questions with the that is asking the part 1. So it's not now required, it is for the task. Okay, there is one questions that is discussed in renal glycosuria. So you are getting urinary glucose, but normal blood glucose is normal. In that cases, you will think it is renal glycosuria. Okay, so that means problem in renal tubular reabsorption of glucose. So the question was, how can you diagnose, or how can you confirm this test? So first you have to give OGTT, normal oral glucose tolerance test, to see that how it is work. then you will go for plasma level of insulin, other causes of glycosuria. Okay, so everything is becomes normal. It means it is renal glycosuria. Maybe they have absorption quality is not appropriate. So you can go through the risk website to revise these things. You will get one questions come several times in the AKP. So you know where is your problem, and you have to solve this. Okay. Now we'll start with the nephrotic syndrome related AGN and HOS. So here I didn't discuss with tumor, that I will discuss in the hematology chapters. So Yin's tumor is very important, nephroblastoma. Okay. Imagine is important, that we will discuss in the. Okay, just 1 minute. I'm taking some drink. Okay, sorry. Okay, so nephrotic syndrome related, you do not get very much, easy questions. That means you diagnose nephrotic syndrome, no. Okay. So here, you know, the basic things, just read out these things. Everything is here taken from pediatric guideline. If you just compare, you can understand which things are important. So please don't forget to revise pediatric guideline and the case book. Okay. And here there is some case, but I'm just warning you which is very important. Important things is here. First of all, the complication related. Okay, so we know that nephrotic syndrome patients having high generalized edema due to hypoalbuminemia and massive proteinuria is there, and hypercholesterolemia is there. Okay, so why hypoalbuminemia? It is not asked here, but it is the most important things. Remember things. You can get massive proteinuria by dipstick test. So it's not very important to, initially to diagnose protein creatinine ratio. You have to do this, but you can easily understand by dipstick test. But severe hypoalbuminemia, hypoalbuminemia here is specifically categorized less than 2.5. You see, less than 2.5 gram per deciliter. So it is not, it's commonly albumin is from 3.5. But here for nephrotic syndrome, it's a syndrome. Here it is less than 2.5. So it has specific importance. So remember these things. Other than this, there is some complications. So complications is mainly hypovolemia. And hypovolemia, how can be described? So it could be like, that it could be tachycardia, and most important things. But hypertension would be the primary as a features of hypovolemia. So blood pressure primarily become low, then become high. Sorry, primarily become high, then become low. So hypertension is an indication of hypovolemia. Remember these points. But tachycardia is most important. You have to pick up the patient which is going to be hypovolemic early. So you have to see the heart rate or pulse. Okay, and they can present it with abdominal pain with, okay, and capillary refilling time is important but very difficult in edematous patient, and it's difficult, they are weight loss or gain. So most important things we say, heart rate, blood pressure. And then you can get hypovolemia. When you get, then you have to give that shock, that means you will give 0.9% sodium chloride. But if you have albumin 4.5%, you will give as a 20 ml per kg over 30 to 60 minutes. Further required, you will discuss with PICO, even not the pediatric nephrologist, PICO, giving further bonus. But if mild hypovolemia, that means you give 20% albumin with furosemide support. Why? Because we are thinking always with volume overload. Okay, so other than this child could be suffer from peritonitis, so severe abdominal pain or mild abdominal pain even. So recognize is difficult, and we have to send the fluid for analysis as well as blood culture. But what is the antibiotic name? It is the tazobactam piperacillin. So one recall question is like this: patient having such a edema and abdominal pain or something. So what is your treatment option? You have to go for tazobactam piperacillin. Okay, so this is written, tazobactam piperacillin, it is written in the pediatric guideline. So I can choose ceftriaxone or something, but guidelines say I will tazobactam piperacillin. Okay, the child could be suffered from thrombosis. That means you have to give dipyridamole if there is severe edema. Child would have easily infection, so you will give prophylactic penicillin if edema. Okay, child could have we know that child could have even thrombosis in the head, sagittal venous thrombosis, deep venous thrombosis, so presented a severe headache, or leg edema, leg pain, and you could not ascertain any pulse in the leg. So deep vein thrombosis in the leg also could be. Pulmonary venous thrombosis could be, renal venous thrombosis could be. So thrombosis, if they are, then you will, again, the edema management you give, thrombolytic agent you will give, but management investigation is the ultrasound and Doppler study. Okay. Okay. But here, most important things is refer to pediatric nephrologist when there are some questions like this. So I'm just discussing these things with you. I need a space. I do not get space. Okay. So management is fluid restriction and weight. Then you will go for 3P, prednisolone. Then you will go for PPI for prednisolone to prevent gastritis. Then you will go for penicillin. Okay. And then dipyridamole. It is the management, nothing more than this. Remember what I'm saying. It is also, if you can remember these things, it's also will be helpful in your clinical exam even. Okay. Okay. After then, remember, nephrotic syndrome is usually minimal change. When there is nothing serious, you can get minimal change disease histologically. There is electron microscopy on any abnormality, but normal microscopy get no problem. So minimal change means age is supportive, there is no macroscopic hematuria, hypertension is explainable, and there is no renal abnormalities, impaired renal function is not there. So it is minimal change. But when it is resistant, then it could be focal segmental glomerulosclerosis and other varieties. Okay. Now, when you refer, referral criteria. When to refer and how you want to refer. So it is first you can take the age less than 1 year, more than 12 years. Okay, it is the referral criteria first, and then nephrotic syndrome related, that is steroid dependent nephrotic syndrome, steroid resistant nephrotic syndrome, or nephrotic syndrome with steroid side effects. Okay. Then if the nephrotic syndrome with some lab investigation, C3 low. Just 1 minute. Okay, so C3 low, ANA positives, macroscopic hematuria, and there is impaired renal function. So these are the pediatric nephrologist referral, other than you can manage as a pediatrician. And now nephrotic syndrome patients, and these patients having what I want to say, what other things? Okay, indication of referral I discussed. Oh, yes, admission. When admission? First case have to admit, whatever the presentation. Patient requires some education, so you will admit. Other than this, you have to, any child who have some complications, they will refer. They will admit. Okay, but every relapse case is not required. You will discharge the patient with advice. Which advice? Prednisolone related some advice. Have to continue, and sometimes maybe prednisolone require double dose when infections come. Okay, upper respiratory infection, then they will double the dose. So prednisolone cannot be suddenly stopped, and the vaccine related, they cannot take any live vaccine within 3 months. Okay, and how they understand the relapse? They will do the dipstick test, especially daily if child having any upper respiratory infection, fever. Otherwise, weekly they have to be follow up with dipstick test. Okay. So if they get every subsequent 3 days positives, 3+, then they will comes to the GP center for further follow up. And they have to be immunized with which kind of vaccine? Pneumococcus vaccine, and they will have to know that how their varicella status, so that they can take precautions. And must you have to say that varicella, contact with the varicella, then they have to become, because you have to give some prophylactic measures. So I think it is enough for the nephrotic syndrome. And there is something here with the new format that is very, very easy to diagnose. So 10 years old who found have proteinuria, 4-year history of rheumatic factor positive polyarticular GI that has been treated with weekly IM methotrexate. The dose of methotrexate had recently been reduced from because of raised hepatic transaminase. Arthritis not currently well controlled. There is no history of pre-existing renal disease, no family history of renal problem. Her grandfather had sarcoidosis. So this is actually, this new format case is not very good case, because here they make it more complicated and no questions you get these types of things. So from here, just you see that patient having GIA, they're having history of sarcoidosis, and they're taking methotrexate. Now child having protein creatinine ratio high, and serum albumin was in normal range. So here you are not thinking nephrotic syndrome. Okay, so you are not thinking here nephrotic syndrome, because normal albumin level. Okay, so here it could be due to normal albumin is in the normal. Yes, here it should not be the nephrotic syndrome, rather than it could be interstitial nephritis and amyloidosis also. So I think here I didn't write the 1-5, I write it, but the answer would be here interstitial nephritis and also renal amyloidosis. Okay, so it is a complicated. If you go through the 7.15, you will get these things. Just here, learning point is normal albumin level is exclude that it's not a nephrotic syndrome. It is written serum albumin was in the normal level, but protein creatinine ratio was high. So proteinuria due to interstitial nephritis could be amyloidosis, could have proteinuria. Yes, I'm right. Sure. And here just they discuss with nephrotic syndrome, typical nephrotic syndrome, edematous patient, blood pressure and pulse and hemoglobin normal. So two investigation would you want to request? Child having edema, okay? And you get many things, but you have to know that child, what is the other things you want to know? So abdominal ultrasound, pulse oximetry, urine analysis, blood protein, serum osmolarity, full limb blood pressure. When a edematous patient and when you get an edematous patient and they have normal creatinine and in that cases you have to know the urine report. No? Without urine report, how can you understand? You have to know the urine analysis and I am searching for serum albumin, it's not there, so blood protein, okay, and also lipid. Why lipid? Because of serum cholesterol. Two, I have to confirm that nephrotic syndrome is there or not, because it could be, I mean, more than 1 year, it could be. Okay, so after then, two, what is your management? Management, what could be? You have to go for fluid restriction and steroid. Okay, fluid restriction and steroid. We say it's very important. Here, I just want to mention you that some questions are congenital nephrotic syndrome. There is congenital nephrotic syndrome within 3 months. If you get a birth, that congenital nephrotic syndrome, they are presented with severe anasarca. I mean, there is a body fluid, 2 or more body organ involvement, severe anasarca, then congenital nephrotic syndrome or infantile nephrotic syndrome when it is less than 1 year you get. So infantile nephrotic syndrome. Congenital nephrotic syndrome, usually they are resistant type of nephrotic syndrome. Focal segmental glomerulosclerosis is their pathological type. Okay, and treatment is same as like albumin and steroid. Okay, so but their prognosis bad and they invariably goes to the renal failure. Congenital and nephrotic syndrome mainly, but infantile also their prognosis is not good. But when child having severe anasarca after birth, then you have to think over this. No, nephrotic syndrome could be parvovirus infection and other differentials could be. It's not working sometimes. Okay, now glomerulonephritis related, mainly acute streptococcal glomerulonephritis. They will give you a scenario having complications. So child having some edema and there is seizure, convulsion, I mean, so blood pressure is very high, but creatinine is slightly high, recent onset, these things. So you have to think over the glomerulonephritis, I mean, hematuria, hypertension, impaired renal function. So 3H, hematuria, hypertension, and high creatinine. This indicate glomerulonephritis. You have this idea that acute, not always they give you that that edema and previously upper respiratory infection followed by this one and you get hematuria. So question is different here. If you just go through the recall, you can understand. It's slightly different. Okay. And they are much concerned with the Alport syndrome than good posture syndrome. But remember, good posture syndrome is GN features along with some pulmonary problem like hemoptysis. Okay. So remember, the good posture syndrome features is like this: renal manifestations with pulmonary hemorrhage. Your mode of treatment is antiglomerular desmoid antibodies. Mode of investigation, antiglomerular antibodies become positive. Okay, so this is good posture syndrome. Some questions with hemolytic uremic syndrome, very easy. Although, if they give you the diarrhea followed by child become pale, you should think over HOS. But it could be anything. I mean, if there is acute AKI, also could be HOS. So AKI is one of the component of hemolytic uremic syndrome. Other component is there would be hemolytic anemia and thrombocytopenia. So to fulfill the diagnostic criteria, what you have to do, you have to go for CBC with PBF, which is very important. Okay. So PBF will see that child having thrombocytopenia and hemolytic anemia. And then child having AKI, so could be respiratory distress, like for metabolic acidosis, anuria, oliguria, could be their manifestations. So don't forget this scenario. So cystocyte, you can get in the PBF, some breakdown of RBCs there. So usually having history of diarrhea, other than diarrhea could be, but they are that's called atypical HOS. Okay, and their complication could be anything like from head to toe. So it could be intracranial hemorrhage, it could be diabetes mellitus, it could be rectal prolapse, it could be severe abdominal pain as manifested is intersusception, perforation, toxic megacolon. Okay. You have to do the electrolytes and other things, and then what you will do, you will immediately admit and then discuss with the regional pediatric nephrology team. So you understand, HUS means admission. HUS means admission. It's not like nephrotic syndrome. You will admit and you will discuss with the pediatric nephrologist of all the cases of HUS. And you will give the other management. Here, important things is anemia. You will accept anemia up to 6. You will not give any transfusion. For thrombocytopenia, same. So thrombocytopenia, you will give the transfusion only if there is intracranial hemorrhage or any procedure you have to do. For anemia, if you want to give the transfusion, you have to talk with pediatric nephrology team. Okay. Then sometimes require dialysis, then patient need to refer urgently to the pediatric nephrology team. Okay, during the discharge, I mean when child is stable, you have to give the folic acid until hemoglobin become normal. And these child require, their follow-up actually very interesting. You should remember that this child require follow-up until their renal function becomes normal. So it is the pediatric renal follow-up is required. After then, they will, when child becomes stable, even they will yearly, every year they will do the BP monitoring. Okay, and then 5 yearly they will go for protein creatinine ratio and GFR measurement 5 yearly up to 15 years. Okay, you will do the follow-up. Okay. Now we will read this ectopic case. Okay, so a 6-year-old boy admitted with the pallor and tiredness and ongoing diarrhea. He was sleeping more than usual. His appetite drinking has diminished. urinary output had slowed. He had unwell a week before earlier with the 3-day episodes of abdominal pain, diarrhea, vomiting, not the but the bloody diarrhea, although still present, was improving. He has previously been well. On examination, pale, quiet. There's no evidence of rash or other cutaneous lesion. Temperature, heart rate, blood pressure, heart sound normal, respiratory examination normal, mild degree of generalized tenderness, and there is hepatomegaly. Blood hemoglobin 7.9. MCV, MCH, MCHC, white cell count, platelet count. So what is the likely causative agent? The scenario is very hard. I mean, many things, but the agent for clinical presentation. So it is HUS now. What you get here, HUS, there is diarrhea followed by you get renal function abnormal, high creatinine, potassium become high due to renal failure, STLT is normal, and there is a platelet count where hemoglobin is low, but platelet count is normal. 19 into 19, yes. So platelet count is normal. Whatever it is, we can think over that this is a case of HUS because child having diarrhea with pallor, there is some abdominal complaint, urinary output becomes slowed and high creatinine. So we have to think over this. Sodium is slightly higher, potassium is also higher, high urea. But MCV, you see, MCV is 72. MCH also normal. Okay, so it is due to hemolytic anemia. So what is the causative agent? It is E. coli, not Shigella. Only for the developing country, but for this country, developed country, we go for E. coli. So how they get the E. coli comes it is by the exposure to the animals. I mean undercooked meal, especially when they eat the stick. Okay, undercooked meat and dairy products also. Raw milk when they eat, then they get this E. coli, sugar toxin producing E. coli. What is the following a recognized complication? Pancreatitis, pelvic, septic arthritis, subphrenic ulcerative colitis. So pancreatitis is a complications. Okay. So, okay. I think we are coming to an end. Just few things I want to mention from beginning. So unilateral hydronephrosis, bilateral hydronephrosis. So if bilateral hydronephrosis, then you can think over that obstructive bladder, the obstructive pathway. So it could be bladder or urethra. So posterolateral valve is important things. But when unilateral hydronephrosis, then think of pelviureteric junction. PUG obstruction is very common, but we can get vesicoureteric junction obstruction also as a cause of unilateral hydronephrosis. So hydronephrosis means we know that collection of urine in the kidney. So kidney becomes enlarged, and in that cases our first task is to start after, so it could be, I mean, recognized later, or it could be in the antenatally jelly scan can recognized. So we have to follow up, and the last trimester, if we get the hydronephrosis and the hydronephrosis is bigger, in that cases we have to start, I mean, hydronephrosis is there, that means after birth we will start prophylactic antibiotics. Okay, and then we will do the ultrasound. One is for unilateral we'll do at 4 to 6 weeks, but if it is bilateral male child, we have to go for 48 hours ultrasound. Okay, and if we get that it is like posterior, then they do the surgery immediately with the MCUG. Okay, but if it is normal, then we'll stop antibiotics. I think one question is like this, and never miss these X-ray features of hydronephrosis, okay, by the eye view. So it is not the MCUG. So it is the eye view features. Okay, so it could be there. And and also there is many questions with the Alport syndrome. A genetic syndrome affecting the urinary system. So Alport syndrome, one of the things, many questions. With the GN features, you will get deafness. So if you get the deafness or family history of deafness with GN features, you have to think about the Alport syndrome. So Alport syndrome having diagnosed by the skin biopsy, and you have to refer this patient to the pediatric nephrologist. But here mainly they ask you the, I mean, Alport syndrome related features will be there, deafness. Okay, and we discuss about the cystinosis and also the Lowy syndrome. I think there is a very old recall that Lowy syndrome related, where you will get amines, that is the proximal renal tubular acidosis like features, aminoaciduria, glycosuria, with proteinuria and cataract. Okay, then it could be oculocerebrorenal syndrome or Lowy syndrome. There is another things, that is the prune belly syndrome, when you get that child having absence of lower abdominal skin with cryptorchidism, then you will think over Eagle Barrett or prune belly syndrome. Okay, usually they are associated with bladder outlet obstruction, which lead to oligohydramnios and pulmonary hypoplasia. So actually, it is the Potter syndrome or Potter sequence. So Potter syndrome means when they have oligohydramnios and having some specific features in the body, like they have limb abnormalities, they have this characteristic faces, and you can get that pulmonary hypoplasia when there is urinary problem, renal problem, then less urine output, and there will be oligohydramnios and these features. So it is Potter syndrome. So if you get other than renal cause, there is some oligohydramnios and then can lead to these features. It's called Potter sequence. Okay. Other than this, here it is discussed. Okay. So what is the causes? Potter sequence, or autosomal recessive polycystic kidney disease, obstructive uropathy, bilateral renal agenesis. This could be chronic placental insufficiency. So renal and non-renal both cause could be. Okay. And this X-ray is related with the pelvic kidney. You see, it is a pelvic kidney. And there could be fused kidney. There is duplex kidney as well. Duplex kidney means you see that duplex systems. So double kidney or double ureter, and their features would be constant dippling of urine. Okay, you get it in double ureter. Okay, not miss these things. Um, it is from the MCUG. Okay, so you will just get mainly here urethra and bladder, not above. Okay, so this is all of the nephrology. I hope you understand the whole things. Here it is written what is the recall topics. Okay, and now your task is to read the recall. And hopefully we will miss, I will tell you the letter, the date. Okay, I'm not sure that um, is it, is it, I mean, Thursday or other than Thursday. I mean, it could be early even. So just, I will write it in the group. Okay. So your task is now read the things, whole nephrology, recall everything. I think Dr. Is someone having maybe other than Bangladesh, they could have iftari time. So, and we read many things. So hope you will catch up. Okay. If you are the first reader, then you have you need to take time. Or if you are not the first reader, then maybe someone maybe better than me. No problem. We'll discuss with us. If you have any query. Okay, so if you have any query with the recall paper, I mean, when you solve these things, please put it in the group so that we can early discuss these things. Thank you everyone for your patience hearing. In this Ramadan time, you are mostly all of you are present. So I'm very glad for this, and I hope you will complete your reading.